Mr. Chairman, and thank you all for being here today. I appreciate the opportunity to discuss the Medicare Advantage program, especially as the program has grown with my generation nationally and in my district. West Virginia's population is aging, and over a quarter of my home state's population receives their health care through Medicare. Of those patients, of course, 54% of them choose to enroll in Medicare Advantage plans. Patients in my district have gravitated towards MA plans because of their affordability and supplemental benefits that they provide. The time and effort it takes to travel to a doctor in my district is a key factor for many patients when they're trying to decide what particular benefits they want to go with, what plan. So MA plans have become increasingly popular. As MA coverage has increased, we've unfortunately also heard some of the concerns from the patients and providers around prior authorization and payments. You're hearing this over and over. Across the country, rural hospitals and healthcare providers report experiencing lower reimbursements from MA plans, and this has led providers to leave the MA networks, which then creates coverage gaps in rural areas. Dr. Bazell, some quick questions. What can be done to ensure Medicare Advantage plans work with rural providers to allow beneficiaries to get the coverage that they need?
So particularly in the rural, we are not as sophisticated at being able to fight on behalf of the prior authorizations. And so anything that we're doing to streamline that process, you're hearing this same theme over and over again about transparency, efficiency. One of the things that I think is going to be helpful as we talk about this, you know, I'm a clinical informaticist as well, and we always talk about making the right thing to do the easy thing to do. And right now we're not doing that effectively. And so if you can do that, you know, to remove a lot of the administrative burden, that's where I think we're going to make progress.
My second question is really how can we make rural areas more in line with urban areas in terms of access and value?
Yeah, so there's still, when we look at our own provider-sponsored Medicare Advantage plan, I come back a little bit to that network adequacy. It's difficult for us to expand into a lot of our counties because we can't get the specialty access that it requires to be able to even offer MA plans in a lot of our rural counties. And so that limits us to kind of some of our bigger counties. And so I think there's some telemedicine improvements that have helped with that, being allowances of telemedicine to account for network adequacy, but I think they probably need to go a little bit further because that's still probably the primary item that's preventing us from expanding into some of our rural counties.
I've also noticed some of the doctors with certain specialties are now coming to rural hospitals, say one day a month or one day every other week, and I think that helps. Dr. Miller, I've heard concerns from rural providers about the prior authorization process when working with Medicare Advantage. Rural providers are less likely to have resources for dedicated teams to handle their authorization requests and denials. The paperwork associated with prior authorization takes time away from patient care. Can you walk me through the process for a referral for a patient who is covered by Medicare Advantage versus the traditional Medicare? And what are the staff resources required for those two types of admissions? And how can we streamline that?
I'd say it depends upon the plan. It depends upon the service, whether you're talking it's elective surgery, an MRI imaging study, or whatever it is. I actually did part of my training in Cooperstown, New York, a village of 1,400 people in upstate New York at a small 228-bed hospital. So I would say that the main issue is that the administrative friction takes time, and that administrative friction, when unnecessary, takes time from patient care. And that's why I think one of the things that we all have mentioned here is that eliminating those steps of human-driven data submission, human-driven diagnosis coding, like have the clinician drive the data to the plan, but have it be easy. Like I'm sitting next to an informaticist, have it be one click. So a lot of those friction steps in prior authorization is the actual process as opposed to the plan oversight, if that makes sense.
I think so. Thank you. I yield back my time.
Ms. Fee.